Miss Williams?
Yes,
nice to meet you.
Nice to meet you.
Okay, can you tell me what brings you in today?
So my vision has gotten worse for the past couple of weeks, and I feel like it's getting more serious. I went to the drugstore to buy some reading glasses, but that didn't make it any better. My hands and feet are also tingling, but I don't know if these symptoms are related.
Okay. Does anything tend to make your vision worse or better, or do you see different changes depending on the time of the day?
The vision is for the most part constant, but I noticed that it worsens in the evening, especially when I'm driving at night.
So we see from the patient's HPI that one of her chief complaints is blurry vision, and she sometimes sees things floating across her visual field. What are some of the possible causes of the patient's blurry vision? Okay. So you said your vision, you have blurry vision. When this happens, can you describe your visual field?
Yes, so it seems like things are floating across my eyes. Is that normal? Does that sound strange?
Well, okay, we'll certainly take a look at that. Okay, so can you tell me, I have to get a complete picture of your history. So can you tell me what types of medical problems do you have?
So I have hypertension, but I haven't been managing it as well as I should. I also have high cholesterol, and that's another thing that I need to focus on managing and getting up on my medications with that as well.
Okay. So also, what about your family history? What diseases run in your family, especially regarding vision?
So I don't think any eye issues run in my family history, but I know my father passed away from a heart attack at age 60, and my mother has angina pectoris, and that's it as far as my family history goes.
Okay. So can you tell me, do you smoke, do you drink, or you take any recreational drugs?
I smoke back a day. I drink like 2 glasses of wine a day, but I don't take any drugs, and that's it as far as that goes.
Okay, so now I have your social history too. Our patient is a smoker. How can this choice impact her chronic conditions? Okay, Miss Williams, can you tell me, what do you do for work?
I'm actually the secretary in the administrative office at a school.
Okay, that's nice. Let's see here. Yes, I had the nurse get your vitals. I see that your blood pressure was 152/92. So yes, that's something that we definitely need to manage, that hypertension. That's going to be very important. Okay, so let's start the examination first. We'll have you step up to the Snellen chart so we can check your eyes.
Okay.
The eye examination is begun by assessing the patient's visual acuity. The provider directs the patient over to the Snellen chart and will have the patient stand 20 feet away from the chart. Okay, stop right here. So what I'm going to have you do is cover your left eye with your hand, and continue reading until you can't see the letters.
D, E, F, T, O, D. I can't see anything else after that.
Okay, so let's have you do the same thing with your right eye.
D, E, F, T, and I can't see anything after that. Okay, good job. So let's go back to the examination table so I can get a closer look at your eye. Okay. Now the provider checks the boundaries of the visual field, checking for defective areas. The provider places her hands about 2 feet apart, lateral to the patient's ears, slowly moving her wiggling fingers of both hands along an imaginary circular path toward the central vision line. So we're going to check your visual fields, but I'm gonna lift my hands. Tell me, can you see my hands on your peripheral vision? The furthest I can see is, keep going, right there. I can't see past there.
Okay. So what I'm going to have you do now is you cover your left eye, and I'll cover my right. Okay. And tell me if you can see my hand moving.
I can't see past there.
Okay. So we're gonna switch it. And tell me if you see my hand. Tell me when you see it.
I can't see past there.
Okay. Okay.
The provider now performs a physical eye exam. The provider inspects the area over the lacrimal gland and lacrimal sac for swelling, making sure to look for tearing or dryness. The provider begins to check the sclera and conjunctiva by asking the patient to look up and pressing the lower lids with their thumb. The provider then looks for any nodules or swelling and inspects for color. The provider notes the vascular pattern against the white scleral background. So now I'm going to physically inspect your eyes, okay? Let's look at this one first. Can you look up for me? Okay, can you look down? And to the left? And to the right? Okay, good job. Let's do the other one. Can you look up? Okay. Down? To the left? And to the right? Okay. So the physician proceeds to check the cornea and lens. The provider shines a pen light from the side toward the eye, at the same time inspecting each iris. The provider continues the examination with the pen light shining from the temporal side of the patient's head to look for crescentic shadows on the medial side of the iris. She inspects and notes for size, shape, and symmetry of the pupils. Now I'm going to check your lens and cornea. Okay. We're going to do the pupillary reaction test.
What is that?
Okay, it's to check the motor and sensory functions of your eyes.
Okay.
Okay? I'm going to shine a light.
Okay.
The provider now begins the ophthalmoscope exam. The provider places her left thumb on the patient's right eyebrow for stability and then shines the bright light from the ophthalmoscope through the pupil. The provider locates the red reflex, which appears as the orange glow in the pupil. The provider notes any opacities that interrupts the red reflex. While holding the red reflex in view, the angle of view is changed to 15 degrees. There, the provider locates a yellowish-orange structure, the optic disc, and notes the color, size of the central physiologic cup, the clarity of the disc margin, and the cup-to-disc ratio, usually 1:3 ratio. The provider examines the retinal arteries and veins and the macula with the fovea at its center. The provider mentally notes any exudate, retinal ischemia, and a little macular edema with no neovascularization or hemorrhages. Okay, so now let's take a look at the back of your eye. Okay. We're going to take a look at the optic nerve, the retina, and the blood vessels back there. So I'm going to use my ophthalmoscope. What I want you to do is to focus on the spot on the wall behind my shoulder. Okay. And I'm going to press on your brow. Tell me if you feel any discomfort. Okay? Now for the other eye. Okay. Here we note retinal ischemia and exudate on the fundoscopic exam. Okay, so I'm going to just listen to your heart and lungs real quick. Okay. Okay, now take some deep breaths for me. Okay. 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 Okay, great. I'm gonna go leave the room, I'm gonna chart, and I will come right back, okay? Okay.
When the provider leaves the room, she considers the following differentials: glaucoma, branch retinal vein occlusion, macroaneurysm, diabetic macular edema, ocular ischemic syndrome, diabetic retinopathy, hemoglobinopathy, retinopathy. Based on the clinical findings of retinal ischemia and exudate, the diagnosis was narrowed down to diabetic retinopathy.
Okay, Ms. Williams, we need to have a discussion about what's going on. Okay, so I have a lot of things that we need to do to manage this condition. You have moderate diabetic retinopathy, and it's a condition that's going to be managed. What we're going to do first is get you set up with the eye clinic. I'm going to refer you to an ophthalmologist because I need you to establish a relationship
to manage this so it doesn't get any worse. And I'm going to give you some prescriptions. We're going to give you prescriptions to reduce the fluid in your eye. There's a prescription called triamcinolone, and I'm going to give you that. And then we're also going to give you glucophage. We're going to up your glucophage up to 850 milligrams 1 time a day, and then 2 times in 2 weeks after that. And then we're going to up your atenolol also to 80 milligrams to manage your high blood pressure. Okay?
Okay.
And then your blood work came back, and your A1C is 8.13. So you have to get that under control, right?
Mm-hmm.
Yeah, because your A1C is a broad measurement of your blood glucose over a 3-month range. So it's important that it's at a manageable level. Okay, and then yeah, with your diabetic retinopathy in your eye exam, I saw exudate and retinal ischemia. The retinal ischemia is the lack of blood flow, so that's what's causing you to have the blurry vision. You're not getting enough blood supply to your eye, which is important. But with these medications and the treatments, we should be able to improve that. Okay, and so as part of your plan, we have the prescriptions, and importantly, we need to control the diabetes, the hypertension, and the hyperlipidemia. Also, I'm giving you Lipitor, 40 milligrams to control the cholesterol. Okay, so we also have to talk about some lifestyle changes. Fruits and vegetables. Do you have a grocery store that's close to you?
Not really. The closest grocery store is like 10 miles away, and I don't have a car, so I'm kind of in a tight bind when it comes to getting fresh produce. Do you have any recommendations for me?
Okay, that's something that's common to a lot of my patients. For some of them, I've recommended a grocery delivery service, and it's comparable to prices at the grocery store. And hey, it takes out you having to go there. The food will come to you, and it has a small delivery fee. But that's a good option to start getting a healthy diet, which is necessary. Okay, and we also need to talk about the smoking, right?
Doc, I've been smoking since I was in my early 20s.
I know. We're not asking you to go cold turkey right away. We're asking you to reduce, because smoking it causes chronic inflammation in your body, and it worsens any chronic condition that you may have. Okay, along with exercise. You know, we got to start walking 3 to 4 times a week at minimum. But we got to start moving and get 30 minutes in. You'll start seeing some results for that. Okay, so that's the plan that we have in place right now, and we're gonna get you set up with those appointments. Do you have any questions for me?
No. Are you going to set me up with an ophthalmologist? Or?
Yes,
Okay.
yes. That is. He's gonna be Dr. Sharif. I'm gonna refer you to him. He is a great ophthalmologist, and he has great reviews from patients, and he's very professional. So I trust him to be a member of the team in your care.
Okay, thank you so much, Doc. I'm hoping that when I go to him that he is able to repair my vision, and I'll try to set an appointment with you within the next month, and I will be incorporating the lifestyle changes that you recommended into my schedule. So
Okay.
hopefully we'll be seeing some great results.
Okay. I look forward to
Thank you so
continue
much.
working with you.
Okay?
You too. Okay. You can go to the front desk to check out.
Okay.
Thank you.
Thank you.
The case that we have just discussed is based on diabetic retinopathy, which is caused by increased levels of blood glucose, which damages the structural and functional integrity of the retinal capillaries and leads to the loss of capillary autoregulation and primary function, ultimately resulting in retinal ischemia. Treatment for this condition includes diabetic monitoring with tight blood glucose sugar control, and as well as monitoring of hypertension and hyperlipidemia. Laser surgery includes primary photocoagulation, whose goal is to treat macular edema and panretinal coagulation. Injection treatments include using the corticosteroid triamcinolone to decrease macular edema, which increases visual acuity. Vitrectomies result vision to the patient. The surgery is performed when there is a lot of blood in the vitreous, and the goal is to remove cloudy vitreous and replace with saline solution. Lifestyle changes to control diabetes, hypertension, and hyperlipidemia are important as well.